All right, that takes us to the last one.
All right.
Another really important topic, another thing that gets by us some of the time. And so let's talk about Article 12, intimate partner violence, Miller and McCaw. Miller's at Pitt, McCaw's at Kaiser Oakland. It's often those kinds of inner city hospitals that get involved in this, but it is by no means a low socioeconomic thing. This is all across the board, intimate partner violence. And so the CDC definition is on our next slide. Physical violence, sexual violence, stalking, psychological aggression, including coercive acts by a current or former intimate partner. There's a lot of that or former thing going on. Whether or not that partner is a spouse, I think a lot of people in their mind have it that this is only something that affects women. And it is true that it affects women quite a bit more than men, but men are in there at a number that you might find surprising. And here, women 37% overall, 23% severe. You might look at that and go, what? It's out of who? Out of everyone who comes to the emergency department who's ever had it. And so, if you ask women as part of your screening, has this ever happened to you? You get numbers like that, 37%. 1 in 4 had injuries and needed medical care and had gone on to PTSD. Men, 30% overall, 14% severe, so it's a bigger problem in women than men, but it's not at all unheard of in men. In men, 1 in 10 had head injury, and they went on to PTSD and things like that as well. Highest in young adults, 18 to 24, and I personally am encountering it in peds, high school age, 16, with bullying and things like that, and stalking, electronic by media and other things. Other factors that become involved with this, sexual and gender minorities, racial and ethnic groups, mental and physical disabilities are in there. And so intimate partner violence is something that's often not the reason the patient is there in front of you today, but it may be an important part of how you manage them, and keeping open to it, and in some places screening for it is where we're at. Human trafficking is also implicated. Human trafficking is really sneaky. The traffickers often appear to be the caring or romantic partner or the boss. I just want to make sure they get good care. And then they're doing all the talking, and you're like, here it is, the point I just made. High schoolers may be affected. Again, 21% of female students, 10% of male students have had some form of this. And as I said, it's often through social media and other things. Abusive behavior that occurs in adolescence has been tied to that in adults. Routine screening for intimate partner violence may uncover victims. I think California was the first state to have some routine screening, and not all states have it now. Some people bristle at the idea that we should be doing this routinely. Intimate partner violence, when you talk about the psychological aggression, it's about humiliation and control. But because of that psychological thing, they go on to develop health consequences, like their diabetes in poor control, their anxieties work, their asthma flares up, etc. Other tools used by the perpetrators to control their victims: drugs and alcohol, electronic monitoring, health issues as manipulative weapons. You can't get to the ER, you're crazy, you're this, you're that. All goes in there. Interference with attempts to maintain health, so the patient can't get to their medications or to their appointments or refills. In terms of women's victims, they're more medical and gyne and stress-related medical issues. I already mentioned asthma, but cardiovascular disease, arthritis, stroke. Maybe due to activation of their neuroendocrine pathways. I mean, you could imagine this as being your world. You're always on edge, and you're always worried about being hurt or having your partner explode on you or your ex-partner show up. It may contribute to other things: autoimmune disorders, cancer, substance abuse, aging, telomere shortening, all kinds of things about being that stressed chronically. More reproductive issues related to intimate partner violence. Things like unintended pregnancy, because the woman is not having control. Sexually transmitted infections, HIV infection. Providers of reproductive health service are in a unique position to identify this, and this is a big thing that Things like Planned Parenthood get involved with when a lot of people think that Planned Parenthood is all about abortion care and things like that, but it has a lot of this other stuff going on there that's really important. Intimate partner violence is also associated with pregnancy issues, preterm birth, pregnancy-associated death. Service providers have opportunity to intervene and break these cycles. So this is an important problem in the emergency room. It's an important problem in any kind of prenatal care clinics and gynecology offices, pregnancy care, all very important places for this. There are mental health issues about this, increased risk of depression, substance abuse, and PTSD. Anytime you see a woman, or anyone really, with suicide attempt or with substance abuse, I think it's worth, if that's the entry point that they come to the emergency room, about recognizing that the relationship of those things to intimate partner violence is a close one. So depression, suicidality, question, is there intimate partner violence contributing? So it's a bidirectional street. If you start with the IPV, you should ask about suicidality. If you start with suicidality, you should ask about intimate partner violence. Providers who recognize these disorders should consider screening and evaluating for it further. What are some injuries that are suggestive of this? And this is a lot like child abuse, only in a non-child. So contusions, lacerations, fractures, things that don't fit with the story. Head, neck, or face. It's because it's about that interaction. Strangulation and choking is of particular concern. They can actually end up with anoxic brain injury from choking. And anoxic brain injury, and choking is specifically associated with potential homicide down the road. Repeated head trauma may cause permanent brain injury. Literally, people are being slapped around, they're punch drunk, and they become like a boxer who's been beat up too many times, ultimately. In children who are exposed to this, they're more likely to have mental health and physical issues. So in a family, this is particularly destructive. Increased risk of being a victim or perpetrator later. Home visitation programs may help, especially in the child's first 2 years of life. And then intimate partner violence is also associated with these other things listed here: food insecurity. We already mentioned substance abuse, mental illness, and then unstable housing. So both food insecurity and unstable housing are associated with this. Any medical provider may encounter patients who are victims of IPV. So you might in the emergency room, they might at the gyne office, they might happen with family planning, it might happen in a family medicine ongoing outpatient service. But all of those places are things where it might be found. Government agencies recommend screening for IPV with referral if you find something. Interventions decrease the risk of subsequent violence in most, but not all studies. So how could it not do it? Well, it could not decrease the risk of subsequent violence if it happened in a way that escalated the situation, and that does happen in some situations. Compendium available instruments through the National Center for Injury Prevention, and the article has 3 case vignettes. If you want to get into it, which I think are really good, by the way. It's got a full list of hotlines and resources for you if you don't have them available for you. And so all of those things are really nice in this paper. What are the implications for providers? How, where, who really matters. You got to do it in a safe and private setting. You got to get the patient alone to do this. And everyone talks about little tricks to do it. Oh, could you please go out and talk to the registration clerk, or they need to go for an x-ray, or I need to send them here for a urine assessment, urine analysis, whatever it is, you need to get a safe private setting. They might need repeated gentle questioning. I often ask the nurses or our social workers to go further. If I've gone there as best I can and not gotten a result, but I'm still worried about it, I'll often ask other people to see if they get somewhere. And there's a number of times when I've asked questions and got sort of the no answer, but then the nurse or the social worker gets to the truth that I was unable to get there. Offer tangible resources and support. They might need education, and they might need education about their medical conditions and how they relate to this. And despite your best efforts, sometimes they won't disclose. Universal education, RE prevention and harm may improve disclosures. It's a lot of work for that. But to assess the homicide or sexual assault risk once you get into this, you can use tools such as the Danger Assessment 5 questionnaire. It's in the paper. It's really simple. It has things like, have you ever been choked? Has a weapon been involved? Has your children's been hurt? You know, there's this 5-question thing. And if 2 or more are positive, then they really recommend immediate advocacy and intervention. So that's worth looking at, that 5-point questionnaire, and I wrote them down here. The 5 are as follows. 1, has the violence increased? 2, has the partner ever used a weapon? 3, do you think the partner is capable of killing you? 4, ever choked? Choking turns out to be really important in these. Is violence and jealousy a problem? And those are the 5 questions. If there's yes to 2 or more, you ought to start thinking immediate advocacy. Certainly social worker involvement is warranted. Screening without intervention may have little impact. I mean, obviously that's the case. Just screening doesn't cure anything. You have to do something about it. Practitioners need to be empathetic to the victim's individual situation, and you can hear some unbelievable stories in these settings when you get into it. And sometimes you're like, boy, I wish I hadn't opened that can of worms. But that's how it is. If you want to get involved with this, that's what it's like. Again, resources really matter. The social workers are super important and very capable in this. I really have come to rely on them at Stony Brook, and just having them. I'll even hold, if, for example, we're 6 hours on a given day without a social worker, I'll definitely hold them for the social worker to come. And I'll tell them, listen, I got someone to come in and talk to you. And I think it's worth holding them for that. Healthcare system. What are the specific efforts you can do to improve the addressing of intimate partner violence? So staff training, that's happened at Stony Brook for the nurses and others. Clinical tools, like I mentioned, that 5 questionnaire. Workflow and documentation changes. You can follow it up with quality improvement and social services support. As I said, a lot of that has already been happening at Stony Brook. But some of this is pretty easy to do even without those resources. A few documentation changes will get you there. You could easily put that 5-question danger assessment thing into a dot phrase, for example. Online resources available to assist improving care systems and IPV processes. So there's lots of stuff out there about this. This is a pretty in vogue topic to sort of get better at, and there's lots of resources out there. Certainly research is needed to address reimbursement issues related to this. Obviously, as I said, this can be a lot of work, and family counseling is a paid thing and some other things that you might do in the emergency room, but this hasn't been specifically created as a reimbursable thing. Health Resources and Service Administration is working on strategic framework to improve system responses to this, and that's one thing they could do to improve it. So that takes us to the summary. So this is an important topic. At Stony Brook, we see a group that I'm particularly worried about, which is these immigrant farm workers for the vineyards and things out on Long Island. They frequently come in with not their main boss, but with sort of a shift boss who's often sort of speaking on their behalf. I wonder a lot about these, whether they're being trafficked or other things. But the definition, physical violence, sexual violence, shaking, or psychological aggression, including coercive acts by a current or former intimate partner, whether or not that partner is a spouse. IPV, 23% of men and 37% of women at some time in their life, that is, not of that given index visit. Many points in the healthcare where you can get involved. Useful interventions include staff training, clinical tools, social services support. What do you have to say about this, Diane, your experience in terms of IPV, and what have you found that works?
Well, what I'm surprised at is how often when you do kick the door open a little bit, how often they walk through. It makes me kind of sad because I wonder in the past how much I missed in not asking or just opening the door, asking a few little questions that it amazes me. And I think a lot of us know that the multiple complaint person or the person, it's like something's not right here. What's the reason that they're here today? And so I think it's way more prevalent than we remotely pick up on in the emergency department. And yes, you're right. When you kick the door open and they come blasting through where the dam finally breaks and they are sobbing and telling you their stories, which are heart-wrenching. It interrupts your patient flow for something that's super, super important. And those of us that have social work around the clock, it's just a godsend to have that, because and I'll tell you, by the time they tell you that they're a victim of intimate partner violence, it's gone really far. It takes. We did an article on this about 10 years ago for the LLSA as well, that talked about why don't they get more? Why don't they leave? People always say, well, why don't they just leave? It's so complicated. So by the time they're willing to tell you what's happening, they're ready to do something about it most of the time. And it's this little window where you can make a gigantic, huge impact on that person's life. You can't just. It's time. It is time, and you were the person to help catalyze that.
One thing this paper didn't address is that anytime you're seeing a kid, you're thinking of child abuse. You got to start asking that mom, at a minimum, about her safety as well.
Exactly, and I think we get so focused on the kid we forget that. Yeah, absolutely. So we got through it, Billy. This is good.
The other thing I would just say about this paper is I know I don't find as much of it as out there. I find some. I have good social work resources. They do come through the door on occasion, and of the cases that I find, I would say well over 90% are women. But the paper says there's a lot of men, and I can't remember the last man I diagnosed with intimate partner
which is
violence.
kind of... And
so I'm clearly missing those.
Right.
I'm missing those.
And I think there's a whole separate overlay on that of the embarrassment of being a male who's an intimate partner violence victim. And so that even extra amount of, gosh, how do I even say that my female's partner is doing this to me? If it is, and it can be any relationship. It doesn't have to be different gender relationships. It's the same gender relationship. It can be any relationship can do this. Anyone can do it. Well,
Diane,
Billy,
I want to thank you for all your work, and because Diane put together the slides, and it was a pleasure to do this with you. And for all of you out there, good luck on your exam. I hope we hit the points that appear on the test.
Absolutely. Yep. Thank you, Billy, for doing this again. It's been fun. I apologize for my cat jumping on the thing in the background. So there we go. And do well on the test, and we'll see you next year.
All righty. Good night.
Bye,
Good day.
everybody.
Whatever it is. Bye.